All right, we are recording now, and I want to thank Dr. Specht for presenting today's journal club on NSAID use in feline CKD. And if you folks have questions, feel free, you can put them up in the chat, or just certainly turn your microphone on and ask them as we go to engage in the conversation. And really exciting for the session, so thanks a lot.
Yeah, thank you for the opportunity. I'm glad I felt like I should contribute. So I was looking for a week when I thought I would have some time. I do apologize with COVID. I got a little busier before this than I anticipated. So I didn't have as much time to make this as interactive as I had hoped. But hopefully that will come from the chat questions and maybe a discussion at the end. The paper that I picked, as far as the specific paper, was this recent one that came out on effects of low-dose meloxicam in cats with chronic kidney disease out of Kansas from Dr. Kakanich. And I kind of like to start almost all my presentations with a quick why. So why did I pick this paper or this presentation? In this case, it really relates to my career as an internist and sort of a discomfort with the topic in general. So certainly when I first came out of my residency, I would say, you know, my general sense of NSAIDs was NSAIDs equals bad. And I've seen that certainly in a bunch of other internists as well. So I'm not sure that was unique to me, but I had some experience certainly seeing patients get things like NSAIDs in anesthesia and develop kidney problems, and was fairly fearful of them in most situations. As I'm older, my comfort or use of them has sort of evolved over time. So you'll notice there's no happy face on here. I still have the sense that there's rarely situations when I think, yay, NSAIDs, and don't worry a little bit about the side effects. But I am much more comfortable in my general patient population with, if I need analgesia and my patient is not dehydrated and doesn't have what I consider to be significant risks, I have certainly grown fairly comfortable with saying, okay, they're eating, drinking, I don't have major abnormalities on my chemistries, I'm going to feel comfortable giving them NSAIDs and monitoring. That comfort level has not extended to the patients that have pre-existing conditions. So if I think about how I think about kidney disease, particularly feline kidney disease, certainly didn't get as comfortable as quickly, to kind of terrified most of the time, a little more comfort just because sometimes you need them. And then some papers came out that made me feel really reevaluate my thoughts about NSAIDs, particularly in kidney disease. And these are part of the background of this paper. So for me, those two Gowan papers were eye-opening. Here's a patient population that gets chronic NSAIDs and they don't all immediately tank their kidney disease. So it opened my eyes a little bit and made me interested in the topic. So when this one came out, and as a prospective paper, was really interested to see how it would fit into that literature and with those previous papers. So for this particular talk, what I'm hoping to do is I'm going to go back and review those papers very, very briefly, basically one slide a piece, and then get into this actual paper that we're talking about, since it is a journal club. But then I'm going to dive a little bit more. Instead of doing the intro in the intro, I'm kind of going to go through the paper and then come back and revisit a little bit more of the pathophys and literature around this topic, and finish up with just a couple slides on where I think we can go from here with the information, both from this paper and from other literature. I will say number 3 is the other reason I picked this talk, because my general knowledge of NSAIDs is also been relatively static. I have not dived into learning more about NSAIDs very much at all, which is a little bit embarrassing, but I learned some things as I hoped, in reviewing for this talk. So hopefully for at least a couple of you, there may be some new things later. So again, very brief review. There's a couple papers that are mentioned in the intro to this Kucanish paper that we're talking about. Two of them were out of Kansas. This was probably one of the key ones. This was a retrospective case-controlled study that looked at older cats with meloxicam and also older cats. So older cats with kidney disease and without meloxicam. And so the interesting part of this really, I thought, was we look at older cats with kidney disease plus meloxicam and older cats without kidney disease and meloxicam. They really didn't change their creatinine much from the start to the end of the study versus when they didn't have meloxicam, there was actually a bit more of an increase in the cats that started the study with kidney disease. So this not only showed that you could give meloxicam to these populations and not necessarily have to worry that they're going to immediately go into crisis, but actually almost had this created this question about, is there maybe even a benefit to meloxicam? They certainly didn't have enough data or info to show that, but it's interesting that the cats that had kidney disease and got meloxicam actually had maybe slightly less variation or less increase in their creatinine over time than the cats that had kidney disease but didn't get meloxicam. The second study from same group, also retrospective, looked at whether meloxicam altered survival when it was given to cats with chronic kidney disease. It was, again, a retrospective study. It also relied on prior papers for chronic kidney disease survival instead of having a specific control group. This table has way more information than we need. I think the one thing to just point out is that, as we would all expect, if your population is older when you start the study, so if you start a study on 15 to 16-year-old cats and follow them for some length of time, even the ones that don't have kidney disease will probably develop kidney disease over time. Certainly some of that could have been related to the drug, but that also probably is a function of age and how we're diagnosing things. I just highlighted these mostly to say this was kind of how, that this was a relatively long amount of time that they had to look at for these, some of these up to multiple years. The longevity after CKD, again, in cats being very good at having chronic kidney disease, fairly long survival times. It would have been a little bit interesting maybe for the ones that ended up in this group to know what their longevity was here, but it doesn't really change the fact that ultimately when they controlled their survivals to historical data, they didn't see a difference. And then the final study from veterinary medicine that's mentioned in this intro is there was a 1-month-long prospective study looking at robenacoxib safety in cats with osteoarthritis. In that subset of in that population of cats with osteoarthritis, a subset of about 40 had concurrent chronic kidney disease at the beginning, and really the key is after this month there was no difference in really any of these values, but probably the one we would look at most would be creatinine didn't change in that time. This was a very short study. There is another study that looked at piroxicam over a period of months in cats, but many of them didn't actually have a lot of follow-up on their kidney values. So they didn't find any change, but they also had relatively small numbers that were tested after the first month. So for people, they do talk about, in this particular paper for today, they mention a couple studies from people. In particular, they were kind of focused on studies that looked at proteinuria, particularly a study that showed that a subset of people with chronic kidney disease actually had demonstrated reduction in proteinuria without significant changes in their creatinine or alterations in their systemic blood pressure. Having said that, they do limit their discussion of the literature in people here. That's fair. There's a lot of it. It's very inconsistent, but I will say overall, I would say it's pretty inconsistent about what the risks are in NSAID effects, but it leans towards there actually being some adverse effects. So if we're taking a closer look at this specific paper, starting with their objectives, they show two basic things. And I also want to say here, I think this is true for any journal club, but since I'm speaking to people I don't know well, if I am in any way critical of points in the paper, it is not intended to be criticism of the study or the authors. I think they actually did a really good job. And it's more, I think, the function of a journal club to talk about the pros and cons and what we can get out of it. But I do not mean anything I say to be intended as a negative criticism, because I think this was a really tough, it's very tough to put a study like this together. So I wanted to start with what their objectives were and what they were looking for. They stated that their objectives were basically to look at the renal effects of low-dose meloxicam in cats with chronic kidney disease, with two specific hypotheses, basically that there would be preserved GFR in the face of that drug, and that there would be decreased amounts of urine protein and urine transforming growth factor beta as an effect of those drugs. A second objective was to basically look with their population to see if there was what the side effects were in these populations, and their hypothesis was that this low dose of meloxicam would have minimal side effects. So in order to determine those things, they set up this study. It's a prospective double masked study with a fairly good follow-up, 6 months. If we were looking at survivals, we would certainly need longer, but I think as far as looking at some of their objectives, that's a reasonable time frame. They have this table in the paper which kind of shows when they collected data and what they collected. There's quite a bit of testing that is done. I think one really nice part of this study is that they actually did this pre-baseline and baseline. So part of their criteria was trying to establish that these patients had stable chronic kidney disease, and the way they did that was to essentially have a collection of data and then repeat that several weeks later to ensure that there was no real change, and then start the study from there. So that was, I thought, a really nice part of this. They did exclude patients if they had suspected or confirmed significant comorbidities, including things like pyelonephritis, neoplasia, stones, or uncontrolled hyperthyroidism or hypertension. They didn't exclude patients based on medications unless there was known reactions. And as far as other renal therapies, it was basically left up to the clinician. The only, which I think it makes sense in a study like this, one of the potential questions I had as I went through it, though, was it was hard to determine from the paper which interventions were applied in which populations, and whether there were any of those interventions that were started during the study, in which case it might affect some of the values. But I don't know if that would be tough to get around of. The one other thing here, as far as kind of looking at what they did GFRs by iohexol clearance at every time point, which is great that we're not just relying on an SDMA or creatinine. They actually are having some GFR measurements. That obviously has its own set of issues when you're designing that study. And so one of the things they mentioned in this design is that they gave all of their patients 100 mils of LRS 2 hours prior to that clearance test, in order to correct for potential subclinical dehydration. And that certainly, I suspect that's a decision that was agonized over quite a bit as far as how to do that. I think by doing that, they get around one potential issue, but they may also then have additional issues. I don't have a good answer for it. I think it was reasonable, and I'm glad they they told us they did it. I went back and forth a little bit on honestly trying to think about whether I would do the same thing. I think I might not have thought about it, but having read this would have to carefully consider that if I were creating a similar study. As far as statistics, they described things pretty well. They basically powered this for effect differences of in BUN, SDMA, and transforming growth factor beta. I thought it was somewhat interesting that that was powered for BUN and not for creatinine. They also did a power for an effect size and not a specific. When I first read this paper, I think I read it as being powered for a difference of 1 in BUN, but it was actually powered for an effect size of 1 in BUN. So that was another thing I went down a little bit of a rabbit hole on effect size. It was an appropriate way to do it, but for values with extremely high variation, which this ends up affecting their transforming growth factor, there was no way. I suspect the variation in that was higher than they thought, because with the standard deviation in that value that they ended up with, there was no way that this was actually powered for an effect difference of 1 in that. So they probably were relying on previous data with a smaller standard deviation. Ultimately, with that power, it was also powered to have essentially a 3-to-1 treatment to placebo ratio, so 3 times as many cats in the treatment group. And those were randomized after stratifying for hypertension and amlodipine treatment. They did repeated measures in novus for change over time with post hoc comparisons for the multiple correction for multiple comparisons. They did do t-tests at each of the time points, and they did exclude a couple values from analysis if there was active sediment. So particularly UPC and UTGF beta were excluded if the urine at that time had an active sediment. They showed a really nice consort diagram. So again, this is nice to see in a paper where we can clearly see how patients proceeded through the study. Nice description of what was excluded or delayed and entered in the study, and where the euthanized patients came in and why. So I'm not going to spend a lot of time on the details here, but I thought this was really helpful to understanding what happened over the course of this study. As far as results, probably the main one that would be compared to the prior studies would be, was there a change in excretory function over this time frame? And essentially their results would suggest that there was not. So in this 6-month period, this is actually over time, I think I cut off the top here, but this is 0 and 1 through 6 months. And basically, if we're looking from start to finish, there's really very little change in, and certainly no increase in creatinine, GFR, SDMA over that time frame, and very little difference between the two groups. So I think their conclusion, certainly that there's not an apparent effect here, is supported by the data. They also were looking at proteinuria. Obviously, that was one of the objectives and hypotheses. And the data here is a little bit trickier. So there is, this is again over time. And this includes one patient in the meloxicam group that was significantly proteinuric. That patient, I believe, is removed from this graph. So they presented the data both with the cat that had a lot of protein and the data without that cat. In both cases, whether you included them or not, there was a difference between protein creatinine ratio in the meloxicam and placebo groups, with less proteinuria in the placebo group. And that was statistically significant. And that was the opposite of what the hypothesis would have been in this case. I think in this case, it's still a little bit hard to interpret, because if we look at, so this difference is significant and this difference is not based on their stats. this difference is probably significant. Not so if I just said it's higher in meloxicam, we might think that's because it went up. But in this case, we had both a decrease in the placebo group and an increase in the meloxicam group. And these groups were relatively small. And so I think while there is a difference here, I would be very cautious about extrapolating or assuming that was that could be repeated. I think that would be something that would be very interesting to know about in the future. It's I would say somewhat, it's mildly concerning, but I have a hard time saying that I think this study shows that meloxicam would increase it. When they looked at adverse effects, they basically found that these were not significantly different between the groups. Again, these are relatively small populations. They did have 4 cats that needed to have the medication discontinued. 2 of those were only temporary for a few days, and then they were restarted. 2 of them were discontinued, and in cats that were ultimately euthanized, it was unclear in those cases whether, when I say unclear, I don't think those were related to the meloxicam, but it's very difficult to say for sure. It was also, I guess, mildly interesting to me that in this small population, there was lethargy reported in 2 of the meloxicam cats, and none of the placebo cats. They're obviously small groups, but that is a side effect that was also reported in the prior meloxicam papers or other NSAID papers in cats. And so it's not something I had really thought of as an NSAID side effect in cats. But I will admit I'm not sure I looked for it. And so this is something I probably would, it was a mild sort of brain tickle where I would say, I might end up paying a little bit more attention to that in cats in the future. So ultimately they go through some points in their discussion. I'm keeping this pretty brief again. Both in the results and in the discussion, I think it's clear that they had attempted to look at multiple biomarkers for renal tubular injury. That data was fairly messy as far as being able, the standard deviations were very big. The numbers were hard to really interpret. There was no significant differences, but also probably would have required a much bigger population to make sense of. The protein data, as I said, is interesting, but I think a little bit difficult to interpret. Safety and side effect data was interesting, but a little bit difficult to interpret. They made the point that because a couple cats in the meloxicam group had their NSAIDs discontinued for some period of time, that they might underestimate the renal effects of meloxicam. I think it was good that they put that in, but I also think that timeframes were relatively small and probably not just from I suspect they didn't significantly underestimate them, but it's good to be cautious about that. So conclusions from the paper, I would say at the end of this paper, I didn't necessarily feel like I would make new or different recommendations for my patients. I think it is good to have, sorry about the typo there, another paper that does suggest that stable CKD in apparently relatively healthy non-dehydrated cats is not an absolute contraindication for NSAIDs if they need them for analgesia for other reasons. It is clear that to really make sense of this, we would still need a significantly larger, longer controlled prospective study. That was kind of where I left it to start. And we'll kind of come back to that at the very end of the talk. So there are a couple questions I still had after reading that. One of them still boils down to this. So this is another paper looking at low-dose meloxicam. And so one question is low-dose meloxicam actually effective as an analgesic? It was in this study and the prior studies, the dose was pretty low. So 0.02 in this study, between 0.01 and 0.03 about in the prior studies. There is some subjective reporting or anecdotal reporting of a benefit at these low doses, but it's important to recognize that there's also a significant placebo benefit effect in multiple other studies looking at NSAIDs. And so if we go through, as far as I could find, the lowest meloxicam dose that had objective data supporting a statistically significant difference from a placebo or benefit in pain in cats was more than double the low dose used here. And so I think it does raise questions if we're saying that this is maybe relatively safe in these patients. We'd also then need to take the next step and say, well, was it effective? And to do that probably would require some actually measuring that as part of the studies. The second question is still, is meloxicam, after all of this, good or bad for cat kidneys? Yes, it probably has some effects, but the answer probably depends on the cat and the situation. I don't think there's enough data here or in the other studies to really answer this. Personally, I'm still pretty skeptical of the argument for NSAIDs being helpful for the kidney disease specifically, based on what we know in people, although we still have that early retrospective. I do think there are situations in which meloxicam can be good for a cat, particularly if their quality of life is impacted by pain, particularly in cases, situations like osteoarthritis. And so if we can help a cat that would otherwise have its quality of life affected by pain without hurting the kidney, it's still a reasonable consideration in those cases. I don't have enough data to suggest that I would give meloxicam because the cat had kidney disease yet, but I might not avoid it in those cases if I thought it was needed for other reasons. This is just going back. I already showed some graph from each of these papers or some data. I mostly included this because I know these are recorded, and if you're interested in the summary, it's basically here, but we now have these 3 prior studies and now this one. And overall, what I would say is none of them really show a significant change in creatinine, GFR, significant adverse effects in any of these populations. And so that is at least encouraging if you feel you have to use them. So that kind of going through that paper, now I wanted to come back to the other reason I was going to present this topic, which is a kind of quick review of NSAIDs actions and maybe pathophysiology effects of NSAIDs in the kidney specifically. So the simple kind of old version of NSAIDs, this is a table lifted from, I forget which company, but advertisement basically for NSAIDs in pets. But it kind of supports the most simple version, which is COX-1 is constitutively expressed and provides support and maintenance hemostatic effects to keep the stomach protected, the kidneys working, platelets working, and that COX-2 is then induced by inflammation or neoplasia or infection and has pro-inflammatory effects when induced. But hopefully if we were to only inhibit COX-2, we would stop these effects and maintain these. That obviously is pretty simplistic. The other, when we think about the kidney specifically, at least my very simplistic thing that I think about with NSAIDs is basically this, that NSAIDs can blunt the normal response to a decrease in renal blood flow and stop this vasodilation and therefore decrease perfusion and GFR. And then that was the main way that we had to worry about NSAIDs causing kidney problems. So I'm not going to go into a ton of detail, but there are definitely some important updates to that understanding of COX-1 and COX-2 and NSAID effects in the kidneys. In particular, COX-2 is actually constitutively expressed in kidneys in at least mice and people. There was one article from Japan I could not get access to that was comparing dogs and cats and had a suggestion that cats may have less COX-2 expression in their kidneys when compared to canines, and that canines were similar to people. So whether this all applies to cats, I think, is still a bit unknown, but certainly in people and rodent models, both COX-1 and COX-2 are in the kidneys. They're both expressed in multiple locations, and COX-2 expression is upregulated by more than inflammatory stimuli. So it's there, and it can be upregulated, especially in times when increased renal blood flow is needed. So in people, there is a suggestion that COX-2 is actually the more important version for helping in situations where, so if there's hypovolemia, that the corrective response to that is COX-2 mediated to a greater degree than COX-1 actually. And so using COX-2 selective inhibitors doesn't necessarily prevent the kidney effects in the same way that we think of protecting the GI tract or other organs. Also, I think important to recognize that it's not just a question of vasodilation or stopping that vasodilation. Prostaglandins produced through that COX-1 and COX-2 action in the kidney have multiple other effects that are relatively complicated. So there is the vasodilatory effect, but it also may activate the renin-angiotensin-aldosterone system, and with effects on volume and potassium. It can inhibit sodium and chloride transport in multiple areas, particularly thick ascending loop and distal, and have a natriuresis effect. And there may be some antagonism of antidiuretic hormone receptors in the collecting duct, and with a diuretic effect. And so if we were then to say, well, what would the effect of NSAIDs be? It could potentially be to inhibit or reverse almost any of these. And so if we actually get into how often does that happen, or what do we know about the effects of NSAIDs on kidneys in people, there are multiple pretty widely recognized or discussed NSAID-induced problems related to the kidneys. There's a few of those that are just idiosyncratic, so specific syndromes of nephritis or papillary necrosis, but there's also some that are probably related to the drug effect. So potential for AKI, particularly prerenal AKI, hypervolemia, hyponatremia, hyperkalemia, potentially exacerbation of hypertension. And then the one that's probably most relevant to the paper here is whether there's an impact on progression of chronic kidney disease. As far as whether there's an impact, there is certainly a concern about that. Because there is a concern about that, that impacts a lot of the studies pretty significantly, because there is a patient selection bias that goes along with that, as well as potentially a patient population effect. If someone knows that NSAIDs are risky for their kidney and takes them anyway, it creates questions about what else they may be doing that they know is unsafe for the kidneys. So I think this quote kind of sums it up. The literature is proportionally vast and filled with incompatible conclusions. So there is no consensus as for this. There are some papers that feel fairly strongly that the evidence is weak for NSAIDs causing CKD progression. And then there are kind of the opposite side, which is that while there may not be strong evidence, the evidence points in that direction, and that caution is still necessary. So I think it's important to note multiple studies in people have looked at this. Many of those studies have much larger patient populations than we can dream of. These are not 100,000 people populations like we see in some other diseases, but they are often 4,000, 10,000, 20,000 people, so significant size. And in most of those, there are small or no difference. So when we're talking about progression of their kidney disease, again, big issues with patient selection bias, and in many of those, the meds end up being discontinued, and so then that creates another question about whether they cause problems. Ultimately, out of that, I think what the conclusions largely boil down to is there is a small risk. It is minimized by appropriate patient selection, and that the effects, when they do exist, are likely significantly dose dependent, both the dose at the time and cumulative dose dependent, so multiple doses. There is not a lot of evidence for low dose NSAIDs in patients that are stable and low risk having progression of CKD or having CKD created by NSAIDs. That does actually appear to be a pretty low risk. So this is one nice kind of summary, I think, though, that does look at those other kidney effects as well as the stages of CKD and kind of points to what evidence we have. Again, the stronger evidence is on the side of these stable, lower stage patients having either no real increased risk or a risk that's very similar to the general population. The weaker evidence, but real evidence, is that this risk goes up substantially if your patient population is older or has higher stages of CKD. And so the risk, not just for progression, but for having these other complications, all of it increases when you get to those more progressive severe diseases, and which I guess isn't a big surprise, but there's some evidence to support using this. And so I think having this sort of idea in mind that the further we go, the more we worry about the risk factors, but we also have slightly decreased evidence is still somewhat interesting. As far as recommendations, I would also point out that most of what's there in the people is still not really talking about long-term use. It's still, again, short-term use appears fine in these lower stages. Long-term, if you're watching for development of those other problems, being very, very careful with any sort of long-term use as you get older, and essentially saying NSAIDs are in fact contraindicated when we're in those severe kidney disease cases. So again, purely palliative, which may be where we are in some of our patients, is more as palliative care. So where do we take this information? I would say, again, none of this probably changes what I would have already had as my practical considerations or recommendations for these patients. I think we should still use NSAIDs cautiously, weighing the risks and benefits in any patient, particularly those with CKD. I still personally probably would use the NSAIDs for relief of pain rather than using them as a treatment for CKD, although we may not have enough information to know about CKD yet. I certainly would consider alternatives, but I think given one of the things we struggle with in veterinary medicine is the lack of good analgesics that our owners can use in a home situation. So I know some people have found gabapentin to be very exciting. I think there are times when I feel it works and times when I feel it's not helpful. Similarly, drugs like amantadine, we still have tramadol. There are options we have, but we are limited for effective analgesics, and particularly when we're talking about osteoarthritis, it is not clear yet that there's a better analgesic than an NSAID. I do think it may make sense to actually use quality of life scoring systems if we're going to do this, particularly if we're going to use low doses. So it's one thing to say that we feel that we've made a difference. It would be nice to have some form of data or scoring to back that up or support that, particularly because if it isn't working. So we might still think it's working in cases if there's a placebo effect, but particularly in cases where it isn't working, it doesn't make any sense to keep giving NSAIDs if it hasn't helped the patient. And so one way to know that would be to have a score associated with it. I still think we pay attention to the same basic risk factors. If a patient is eating and drinking well, particularly I'm a huge fan in cats of having people just buy a scale, having a baby scale at home and using that to follow weight, especially as it relates to hydration status. I think that is personally how I usually guide my fluid therapy recommendations. If I can, it's sometimes hard to convince people to, spend a little bit of money on a scale, even after thousands of dollars of hospitalization. But I think it's really helpful. If I have very stable weight, no indication that they're becoming dehydrated, I feel much more comfortable about this. If there's an indication that they are potentially subclinically dehydrated or clinically dehydrated, hypovolemic, have heart disease, then I would be much more careful. Concurrent meds, going back to that prior slide, it is clear that one of the effects of prostaglandins in the kidneys is actually to mediate renin-angiotensin-aldosterone system, and so there's even potentially a greater impact of NSAIDs if we are also at the same time giving ARBs or ACE inhibitors, similarly diuretics, so be careful with concurrent meds. And certainly, at least based on people, I would be cautious in higher stage CKD cats. Again, if it was a true quality of life, if we were going to euthanize them because of their arthritis and they were not that symptomatic for their kidney disease, I would still treat their pain. But if it was subtle arthritis and they were higher stage CKD, I would probably be much more cautious. And I would certainly be still keeping a relatively high recheck frequency. In light of this recent paper, that recheck frequency would probably include protein in addition to creatinines. I think previously I probably monitored, at least for NSAIDs, I would have said I was paying more attention to making sure that I didn't see an increase in BUN and creatinine. And I probably continue to monitor their protein similar to any other chronic kidney disease patient, whereas now I might watch it just a little closer. I think there's a couple ideal next studies. One thing I didn't put on here is it would actually be helpful to know about COX expression in the feline kidney and whether it has the same physiologic impact as it does in people. And then the other thing, if we were going to really try to evaluate this question of, is meloxicam safe in these patients, or is meloxicam actually good in these patients, we would need a much larger study. It would still need to be prospective. I would still probably be focused on looking at enrolling stable patients, but not just GFR, also stable in their protein, and trying to make sure that their other kidney disease treatments were at least consistent pre-enrollment, if not, so for some period of time, that they weren't being changed as patients were being enrolled or in the early part of the study. It would be interesting to have a longer follow-up and some data on survival. And then I do think it would be interesting to look back not just at progression of CKD, which is really what's been focused here, but some of those other considerations as well. So do we see any of the other problems that have been reported in people with potassium or sodium or volume status in these patients over time? So that's pretty much all I had. I know that was not as much on the paper as I had originally intended when I picked it and was going to go through it. But that's what I have for you today. So if anyone has questions or wants to start some discussion in the chat or the talk, I'm be interesting.
Thanks so much, Andrew. That was fantastic. Really appreciate it. One thing I've always questioned regarding those earlier retrospective studies was the possibility of selection bias. That clearly any cat that didn't tolerate the meloxicam, whether it developed GI signs or maybe acutely developed decompensation, would probably not have be continued on the medication. And I was always a bit reluctant to take much stock in their findings, because it really only was going to report those cats that were able to successfully receive it for a longer period of time, and I think that could have skewed the retrospective studies. So it's really nice to see a prospective evaluation that could capture how many cats might be lost due to GI side effects or renal side effects. But I always thought that that was the limitation of how I would view and use that information from those the several retrospective studies that had been published.
Yeah, I would agree. And I think even with this prospective study, there's probably still a degree of bias, because they're still going to be to some degree selecting for patients that they don't think are like, at least with some of the risk factors. I think there's still probably some selection bias. This it probably isn't including patients that are, although they didn't specifically exclude them. So I don't know. Maybe it doesn't. But I would wonder if a cat that needed sub-Q fluids would be enrolled in this study yet, and I don't know the answer to that. But
Yeah, it makes you nervous if you think that you're struggling to keep the patient hydrated, to then put them on an NSAID, that they might be the population that's at increased risk of developing adverse effects associated with it. So
yeah, so my guess is they didn't, but I don't know that.
yeah, I guess I'd be interested to know, amongst the people that are here, how many people are routinely using NSAIDs in cats with CKD, and are people finding many complications with it? You know, I know when Onsior came out, the company was so thrilled that this was going to be something that was so safe for cats' kidneys, and I know of cats that have had to go on and receive kidney transplants after AKIs that seemed associated with Onsior usage. Now, you know, whether we can prove it or not, I don't know, but we've definitely we've seen patients that were normal before started on an NSAID, and we have seen maybe just those idiosyncratic reactions. So I personally think that there's probably no safe NSAID for the kidney, period, but that doesn't mean we can get away with it. So I'm curious to see what people might be doing. Are people using this low dose 0.02 mg per kg of meloxicam, or something different, or any other strategies? Because it can be really tough to manage these old crunchy cats with CKD in a way that doesn't narcotize them on the gabapentin but still provides some analgesia.
I will say I have not, although my comfort level is mildly higher, it is still, I am always nervous about them in these patients. I have used meloxicam a couple times in older arthritic cats for this reason. One was actually a colleague's cat who did feel like quality of life improved, but again, it's anecdotal, and so I still, and I did use the low dose for that and didn't see any changes over I think we had watched that for about 6 months or so before we did routine monitoring, but I don't have enough to really say that I know. It looks like there's some people in the chat who are sort of saying the same thing. One person over 2 years, so that's good.
think it'd be interesting also to look at a prospective study, and even maybe just starting with normal cats, but just looking at the low dose, the 0.02 mg per kg, and actually doing a pharmacodynamic study. Does it show some analgesic effects? Does it help improve comfort after some type of noxious or unappreciated stimulus? I don't know how exactly these studies are done to show that cats, feel less discomfort. You could, but it would be interesting to see if those low doses are effective in normal cats, that you wouldn't be concerned about the potential for significant renal toxicity, but does the dose work? That would be nice to see some type of pilot study.
I think another thing that would be interesting to look at in these cats would be putting the activity monitors on them and, measuring their activity level prior to NSAID use and then after NSAID use, and seeing if the patients are more active. And then you could use that as a sort of measure of pain level and comfort level with their osteoarthritis.
Yeah, that's actually a really good idea, to see, how mobile are these cats? What are they doing? I was involved with one study in dogs where we did accelerometry and we did gait force plate analysis, but the force plate was way too big to be able to test on a cat. But I would imagine, experimental models exist to test that on mice and rats. So I bet you the technology is out there, but it's certainly not within what I'm comfortable with. Jessica suggests that Duncan Lascelles has done some type of work on that, and I can't say I'm necessarily familiar with it, so it might be an area that I need to kind of dive in a little bit deeper.
It looks like, as far as I could tell, that's where I haven't dug deep into that at all, but his work kind of that's where the 0.05 came from, is that was the lowest meloxicam dose at which they could get objective data of improvement compared to placebo. So they had also looked at 0.025 and weren't, again, there may have been some change, but they weren't able to find a significant difference at less than 0.05 mg per kg.
Certainly, I've seen some cats who have received gabapentin as a substitute for an NSAID, and you have to remember that gabapentin is fairly reasonably dose excreted from the kidneys, and Jessica Quimby has a great story with that, her own personal cats going through some gabapentin sedation when it comes to traveling. But normal dose gabapentin in cats with CKD, you can narcotize those cats, and they might be out to lunch, and they could be super sleepy from it. So certainly another consideration when we're looking at these other possible analgesics. The worse the GFR, the likely the lower the drug excretion is, and some of those are either going to be untolerated from just the effect on their quality of life, but others might increase the risks of having other complications as well too. So, even for those cats with stage 4 CKD, and you want to stay away from an NSAID, even using something like gabapentin with a cat with a creatinine of 5 or 6, you have to give kind of a micro dose, probably once a day, and that still might be enough that kind of knocks their socks off. So it can be really challenging for some of these guys to provide them with some type of analgesia, or with gabapentin, maybe it's just sleepiness. I don't even know how well we're providing analgesia versus just making them maybe sleep and rest comfortably. Any other thoughts or questions or experiences with using NSAIDs or any other type of analgesic for cats? All right, well, Andrew, really, I want to thank you for your presentation. It was great, really excellent review on a lot of pathophysiology and pulling a lot of recommendations from human side of things. So really, thanks so much for an excellent presentation. Really appreciate it.
Thanks.
Hey, Jay, I might make one comment that was brought up early on, and that if you're gonna configure a study to do GFR measurements, and particularly if you're doing urinary collections and you want to maintain a vigorous urine flow rate, what I've done in the past, instead of using a crystalloid solution to provide some fluid to these animals that is going to cause volume expansion and potentially influence the GFR measurements, I've instead used water hydration. And so when we've done this in dogs, we just stomach tube them and give them a water load, which doesn't have those same effects of the salt burden and everything that you would get with crystalloid fluid supplementation. And that has seemed to be a more effective way of promoting the diuresis, so you get accurate GFR measurements without all of the biases and secondary consequences that a crystalloid fluid bolus would have on GFR measurements. So I just throw that out for people that might do those studies in the future.
Great, thanks, Larry, for that comment. Okay, well, our hour has passed. I'll go ahead and stop the recording. And again, thanks, Andrew, for presenting.